So this is, although it's an OSCE session, I'll be just dealing in generally, covering many of these fine topics. Hope my audio is clear, Balu.
Yes, sir. Yes, sir.
Yeah, so I'll be sharing my screen and I'll be also using the whiteboard. So there'll be some lag in between. So you can use the chat box. If you have any doubt and all that, you can ask people. So let's start with this first CT. Okay, this is a CT. It's a very straightforward image that you are seeing. You are seeing actually there is a fracture. You don't need to worry about. Everyone knows there's a fracture in the L3 vertebrae. So you can expect a lot of questions based on this particular topic. One could be, what is the type?
Sorry, sir. Your screen is not visible yet. Srinivas, is it visible?
Yes, sir. Sir,
Right.
share it, sir.
Okay. Okay. Let me just check again. Is it visible now?
No, sir.
No.
No.
Yes or no?
No, sir. No, no.
No. Okay. Okay. But when we tried, it was working, no?
Yes, sir. It was. Sir, please click on share screen button and then you'll have an option. Yeah. Yeah. It's now. It is visible now.
It's already okay. Okay. Clear? Is it visible?
Sir. Yeah. You have shared the screen right now.
All right. So can you see this image? Can you all see this image?
Yes, sir.
Okay. So this was the CT image I was talking about. You can see there is a definite fracture in this L3 vertebrae. So there can be a lot of questions based on this particular CT, or it could be even an X-ray. So one of the first questions would be, what is the type of fracture? Second question would be, what is the mechanism of injury causing this fracture? Then there can be various subdivisions, like how do you classify, what classification of this fracture is, and how do you manage, giving a clinical scenario like the patient has deficit, a motor deficit, like that. So it can go on based on the level of the fracture, if it's a thoracic level, lumbar level, based on which level. But the questions basically would be, what is the fracture, the mechanism of injury, classification, and then management, and so on. So here it is very evident that there is a cord compression, L3, this is dural sac compression, and there is a end plate violation, and also you can see the arrow is depicting that the posterior aspect of the vertebral body is entering into the canal. So here it is a burst fracture. So how do we say it's a burst fracture, and when do we say it's a compression fracture? That is something we can think about. So I'm just going to can you see this white screen now?
Yes,
yes, yes, sir. Yes, sir.
All right. So I hope you guys are familiar with this. It's a very simple one. So I'm just drawing a vertebral body. Okay, this is a vertebral body. Okay, and There's another one below that. So you know that we are dividing the vertebra into 3-column concept. The first one is the anterior column, second is the middle column, third is the posterior column. So when you have an injury, when you have a direct compression force, it's an axial loading, it's an axial compression force which is causing a fracture. So you have a situation like a compression fracture and a burst fracture. The difference is that in compression fracture, you have only the anterior column being compressed. Whereas in a burst fracture, you have the anterior plus middle column. So if you have only anterior column, it's a compression fracture. If you have both anterior as well as middle column, it is a burst fracture. That's a basic thing. Then it can have a posterior extension, plus or minus all that. So this is the basic concept of a compression fracture or trauma spine when you talk about it. So rest of the AO classification like A1, A2, A3, A4, B1, B2, you can actually read up. Now that we are talking about compression fracture or burst fracture, we can also think about something called chance fracture. I'm sure most of you know about chance fracture. There are two types of chance fractures. There's a bony chance fracture as well as soft tissue or osteoligamentous chance fracture. So when you have a flexion kind of an injury or a seat belt kind of an injury, you tend to flex forward. The point of injury is like this. So you can have a crack like this and your vertebrae splits through the spinous process like that. It opens up. So that's a bony chance fracture. So you have a bony chance fracture. And when the force goes through the osteoligamentous complex, like through the disc and the vertebral column or the ligamentous structure, you have a osteoligamentous or soft tissue chance fracture. So in a bony chance fracture, you would see that vertebra gets split like this. It just gets split like that. And you can see the fracture line would be like through the bone. So the bone just gets, split apart, superior, inferior. So this is a classical bony chance fracture. So osteoligamentous, it will be through the bottom, through this plane between the other vertebra. So I hope this is very clear to all the juniors or maybe the first years in this session. So that's about the fracture, basic fractures. So can you see my screen again?
Yes, sir.
Okay. So there can be various combinations of fractures being, shown to you in an OSCE examination. Now we'll come to a very straightforward another X-ray that you can see here. This will be kept as an spotter, an OSCE, and you'll be asked to say what this sign is. So anybody can comment on this particular X-ray and say what do you see in this X-ray? Anybody is interested in answering? It's a very classical, straightforward X-ray, right? Okay, if nobody is answering, I'll go on to say that you can see that in the middle vertebrae, on the right-hand side, the pedicle is not seen. Whereas you see on the top, you will see two big circles. And the bottom also, you can see two ovular circles. So this is called a winking owl sign because one pedicle is not seen. So it's like winking. So you call that as a winking owl sign. It is classically seen in spinal metastasis. Spinal metastasis because the pedicle is pedicle has cancellous bone, and this cancellous bone gets eroded by the tumor cells, and the pedicle also gets eroded. So the cortical outline is missing. So you call this as a winking out sign. There can be a case-based scenario and then showing this X-ray and asking you to write what this is. So this is the picture of a winking owl, that you have two eyes and the one eye is being closed. So that's how a simple question comes up. This is a very short. You should not miss this question. Then there can be various questions if there is a clinical scenario associated with the patient. There may be variations, but it's all, once you see this X-ray, you need to know that we are talking about a metastasis case, and based on that. Then I'm giving another clinical scenario question. Okay, this would be exactly how a OSCE would be, like a 38-year-old presents to your casualty with 2 weeks of back pain, leg pain, then difficulty in passing urine. So that can be a question. And what is your diagnosis? A numbness of the buttocks. So, there's a perianal numbness. This bilateral weakness. Okay, so the first question may be, what is the diagnosis? And there can be various sub questions. So based on the history, a young patient coming to your emergency with back pain, bilateral sciatica with bilateral weakness involving both bowel and bladder, and perianal or buttocks numbness. So this is a classical cauda equina syndrome. Cauda equina syndrome. Yeah, right. It's a cauda equina syndrome. These simple questions will be kept because you should not miss this in a case scenario, even in your practice. And sometimes the patient. So what are the important questions to ask? That's one question. Because in a lady who's wearing a lot of dress, they may not tell you all this numbness and all that. So you need to, ask some leading questions. Are you constipated? Are you having problem with urination? All such questions have to be mentioned. What are the important questions? Then there can be various levels of different kind of questions. What investigations will you do and all that kind of. Sometimes the MRI would be given to you like this, straightforward an MRI. You will see that there is a large disc at the L5S1 level, or they may mark it as L45, and causing a significant compression of the spinal cord, or the cauda equina roots, causing bilateral leg weakness and the perianal numbness. So then another question may be, how do you manage it, or how early you want to operate, and such questions. So based on the clinical situation you need to answer, we need to operate at the earliest on an urgent basis. We cannot wait too long because the changes to the roots and the spinal roots may be irreversible. Can you see my screen?
No, sir.
No, sir.
Okay. Can you see it now?
Not yet, sir.
No.
Okay, great. Is it visible now?
Yes, sir.
Okay, then there's some net issue going on, so there's some lagging is happening. Sorry about that. Can you see this image?
Yes, sir. Yes, sir. Now we
Can you see the screen now?
Yes, sir.
Okay.
Yes.
Oh, right. So
But,
based on the
sir,
IVDP, yeah. So based on the
Yes, sir.
you may have a question on IVDP or an MRI showing a disc prolapse, and there could be a lot of questions based on that also. So there's something I want to discuss very clearly about the different levels of nerve root compression that about paracentral, central, and far lateral disc herniation. But this picture shows really nicely how to know which is a traversing nerve root, exiting nerve root. So if you look at the top, you will see the L3 left pedicle and right pedicle, and you will see two nerve roots going. That is a L3 nerve root. So that is the exiting nerve root at that level because it is going out of the foramen. Whereas if you come down between L3 and L4, you can see there is on the left hand side, there's a big black arrow. There's a big disc herniation, and you can see that that disc is pressing onto another root, which you can see it is the L4 nerve root on the left side. So that is the traversing nerve root at L3, L4. So when you say L3, L4, L3 is above, so that is exiting, and L4 is going through. So L4 is going downwards, so L4 is the traversing nerve root. So it's a simple thing, L3, L4, 3 is above, which is exiting, 4 is going through, so that is a traversing nerve. So you need to be very specific. So they may give you an MRI and will ask you which is the level. So you have to write L3, L4. Next question maybe which is the traversing route or which is the exiting route. So L3 is the exiting route, L4 is the traversing route. Then you can see the below, you can see there is another black arrow and there is a large disc herniation which is going upwards and pressing on to the superior nerve root. So what you need to understand is that the central and paracentral disc will affect the exiting nerve, the traversing nerve, the below nerve, L4. Whereas if the disc goes higher up, upwards into the foramen, it will hit the superior nerve root. So for far lateral disc herniation can affect the superior, that is a exiting nerve root like L4 at the level of L4, L5. So this picture you need to just visualize it and just think about this image. So it's a very useful picture for your future practice and understanding of which disc affects which nerve root. Okay.
Yes, sir.
Hello. Okay.
Yes, sir, we can see it clearly.
Yeah. So you can have another cervical spine X-ray, and you can have these lines drawn on this, and like 1, 2, 3, 4, and you may be asked to name these lines and the importance of lines based on this. So the first line that you see is the anterior line, which is passing through the anterior border of the vertebral line. The second one is a posterior in the vertebral body line. Third one is a very specific name. It's got a name called spinolaminar line because it connects the inner border of the lamina. So it is called the spinolaminar line. So that if that line is narrowed at somewhere, that shows there is a narrowing of the spinal canal. So the line between 2 and 3 is the real line which where the spinal cord is occupying. So that is the significance of line 2 and 3. And line 4 is you can see that the interspinous line. So they can ask you these questions that ask you to name anterior line, posterior line, spinolaminar line, and fourth is the interspinous line. So this is an important point that you have to keep it in mind. So when there is a fracture or there is a dislocation, you will see that these lines are disrupted. For example, when there is an anterior translation, you will definitely see that these lines are broken. So it's very easy. If there is any confusion, you can draw these lines on an X-ray or on a screen, and then you can actually go about it. Then these are another 2 OSCE questions. These may be asked. The first one is like, it's a case scenario like an 8-year-old boy coming to you without a history of trauma, and you see a lytic lesion in the vertebra. That is a question number 7 that you're seeing on top. 8-year-old boy coming to you without a history of trauma, you have a lytic lesion. So what is it? So, your condition called vertebra plana or flattening of the vertebra, can be a lot of options. So in a child without trauma, you see a spinal pathology like flattening or lytic lesion. Usually, less than 10 years, usually it is the eosinophilic granuloma. So that is one question. Similarly, you can have another X-ray or CT, very similar to that, but you can see the difference between top and bottom. There is a sclerosis of the borders of the lesion on the second X-ray. That is the case 8. So in an eosinophilic granuloma, there is a pure lytic lesion. There is no sclerosis around the lesion, and it's a very young boy or young girl. It's less than 10 years. This is another X-ray or CT showing a well-marginated sclerosing lesion. So the question may be, is it malignant tumor or is it non-malignant? There can be various ways the questions may be asked. So you need to say that this is not a malignant lesion, and then they may ask you write some differential diagnosis and what do you think are these like. So one common thing that we see is aneurysmal bone cyst. This is a common thing we see in the lumbar region, can affect the posterior aspects of the vertebra also. So these two things, like between an eosinophilic granuloma and another non-neoplastic conditions, the sclerosis is something which you need to think about. So you can get another CT or X-ray showing another fracture, which is again, you can see it is going through and through the superior and inferior part of the vertebral body with a retropulsion occluding the spinal canal. So you can have a different set of questions. How do you manage, or when do you operate? One question may be, when do you operate? Maybe a question. You can say when the vertebral body collapse is more than 50%, or when the spinal canal dimension is occluded by more than 50%. You can say that these are the indications. And also there's a neurological deficit. So these three answers should come in the question when it's asked. So you can again have another set of questions showing a disc compressing the spinal cord at various levels. This is the lumbar spine. And again, the symptoms may be a cauda equina symptoms or maybe an IVDP symptoms. Based on that, there can be questions can be varied. So. Then you can have another scenario, like another case like this. There may be a history like a 20-year-old girl is coming to you with neck pain and with high-grade fever for 2 weeks or 3 weeks, and then she's coming to you with some weakness of upper limb or lower limbs or things like that. So whenever you see a history of fever and neck pain or back pain and a younger age group, they may give you a high CSR, CRP values, etc. So back pain or neck pain combined with the history of fever, history of urinary tract infection, or history of any other infection in the recent past, you should think of an infective situation. If the fever is high grade for say 2-3 weeks or very acute in onset, we are thinking about bacterial infection like a pyogenic infection. Or if there is a very mild fever or evening rise of temperature, if the question is like that and it's a long duration like 2 months, 3 months with a vertebra collapse or an MRI showing an abscess, then you should think of a little bit more chronic lesions like a tuberculosis of the spine. Usually you may be given a case of tuberculosis of a spine, which is known as the pot spine, and you may be asked to come to a diagnosis based on the history, X-ray or MRI, or maybe there's just an X-ray is presented to you like this. So you have to go by the history. How long is the duration? Short duration, long duration, and what about the fever? Is there a loss of appetite? Is there a loss of weight? It will be just like a clinical case. You have to think and you have to come to a diagnosis of an infective lesion, whether it is acute or a little indolent phase. So in such cases, you have to write your diagnosis is tuberculosis of the spine. And then the sub questions may be, what are the different types of TB spine, or which are the different types of things? So you should know the classification like paradiscal, central, posterior, or appendiceal, all those things. This is a very interesting case because this has a vertebral planar kind of a picture. This happens in a central type of tuberculosis because it is involving the center of the vertebral body. So the body gets collapsed. So it is called a central type of tuberculosis. Then there can be various different questions depending on the center where you are going. It could be like, what is the cause of destruction, or what is the cause of this illness as such? Is this the tubercle bacilli that is causing this problem, or is it something else? So you need to know that the answer is it's a delayed type of hypersensitivity reaction that is causing tuberculomas, which is causing caseation, which is causing granulation, which is causing edema, which is causing destruction of the bones. So just like the COVID virus that we are talking about, it is not the virus that is killing the person. Similarly, it's a our immune system is fighting against it. Similarly, in tuberculosis of the bone or spine as such, it is not the bacilli alone, because this is a paucibacillary condition. Unlike the lung tuberculosis of the spine, tuberculosis of any part of the bone, it is a paucibacillary condition where the number of bacilli is quite less. So it's a delayed type of hypersensitivity reaction of the body towards these bacilli is causing all this destruction and compression of the nerve roots or spinal cord at whichever level may be. So then you may be asked, what are the relevant investigations that you would do? Like you would be doing an ESR, be doing a CRP, and then there is another condition that it can cause an infarction of the spinal cord without a major compression. That's a vascular cause. The microvascular supplying the spinal cord can get ischemic due to this small thrombosis. So that also can happen without a big lesion happening or big pus or granulation tissue. Then you could be just asked the word SCIWORA, Scivora. They would be just written Scivora. What is this? So you have to just expand it. Anybody willing to give a shot at this? What is Scivora?
Spinal cord injury without radiological
abnormality.
Yeah, you're right.
Abnormality.
It could be just given like that as an OSCE. So Scivora is something you need to read. There may be some questions based on the Scivora. So this is the same patient's MRI, which I was showing you the X-ray. So you can see this. Then you may be asked which sequence is this image. For example, this sequence may be kept, and you may be asked which sequence is this? Is this T1 image or T2 image, like that? It's a very simple, plain, straightforward. You will know that in T2 water is white. You all know that. The CSF, you can see it's very white in color. And also anterior to the C7 vertebrae, you can see there's a big collection. That is a prevertebral collection. Also, there is a post-vertebral collection. So that collection is also homogeneous or whitish in color in the anterior aspect. So you can say there is a collection happening there. Whereas on the other image, you can see this is a T1 image, T1 weighted image, where you see the CSF as dark, and that's how you would see. T1 is for pathology. T1 will give you a more idea about the pathology of the bone marrow, how the marrow looks like. Is there a So the radiologists depend a lot on this T1 weighted images to comment on pathological like metastasis, lymphoma, or other blood malignancies affecting the spinal cord. So again, the same picture of the same patient. You can see there's a large abscess compressing the spinal cord at this level, and this one is without contrast and with contrast, etc. I was going to discuss about this. That's when the problem happened. We will definitely get a question on spondylolisthesis. Usually, it may be an X-ray, CT, or MRI, and you would be asked to identify which part of the bone or which part of the vertebra is the lysis or affected. So the answer should be pars interarticularis. Pars inter, or what is the word meaning of that particular pars interarticularis? The word meaning is the bone connecting the interarticular region. Interarticular means there is a superiorly, there is an articular area, articulation, and there is an inferiorly articulation. So the area between two joints, it's the strongest part of the posterior aspect of the vertebral body. It's a very strong bone. This is one above and below. So pars interarticularis, a break in the pars interarticularis causes the spondylolisthesis. Can you see my screen?
Yes, sir.
And rarely, I'm not saying rarely, there may be a question on scoliosis of the spine. It may be kept, an X-ray may be kept, and a case history also would be given. Because when I went for the DNB exam, I got scoliosis as a short case. So it may not be a straightforward scoliosis case. There'll be a case history. There'll be a proper history. And usually they would be keeping a patient with some anomalies other than the scoliosis itself. Yeah, so you need to know the other conditions associated with this, the scoliosis. So one question could be, what reflexes you will check? What reflexes you would check? Anybody can give me an answer? Which reflexes that we usually check in a scoliosis case?
Superficial abdominal reflex.
Anybody? It can be wrong. No problem.
Superficial abdominal reflex.
Okay. So what we check that we talk about is, yes, great. That's a superficial abdominal reflex. What do you actually look for in that? What do you look for in the superficial abdominal reflex? Is it just the presence or absence, or is it anything else? There can be a question on that. Which reflexes would you check, and how do you make out of that? So there can be many answers. One is absence of superficial reflex. Second one is asymmetry of the abdominal reflex. You can have reflexes on the right side and absent on the left side. So these two answers should be there. The absence of abdominal reflex or asymmetrical absence. May be completely absent or it may be partially absent. Then what are the other associated conditions associated with the, I'm talking about the spinal cord only, which have to be looked at. If you find that the patient has associated, lower limb deformities like a cavus foot or foot abnormalities, like a CTV kind of a picture of, usually they have a high arched cavus deformity with scoliosis. What is it? What is the associated condition? Anybody? Scoliosis plus lower limb deformity. What is the condition that is causing that in the spine? Anybody? You can just give a
Spinoarthrogryposis.
okay. It's okay. What I was asking is the tethered spinal cord. Tethering. No, the tethered spinal cord. We are talking about a growing child, like in a 10-year-old boy, as he was becoming 11-year-old, 12-year-old. You're getting that case. He has a high arched foot and some walking anomalies because he has an associated tethered spinal cord. As the child grows up, this is a tether. Tether is something like a tie. The lower part of the conus is tied to the sacrum. So it is not allowing the ascent of the spinal cord, which normally lies at the spinal cord ends at the L1, L2 level in an adult. But in a tethered cord, you will see that the spinal cord is lying very low, like L4 or L3 or L5, because of this tie. This tether means you are getting a tie. Something is tied to it. It's not allowing the spinal cord to go up, so that as the child grows, there's a strain on the spinal cord, and that can affect the lower limb nerve roots, causing various combinations of foot deformities. Then there can be another associated condition called Arnold-Chiari malformation. You can have an associated Arnold-Chiari malformation. They can show you an MRI and ask you what abnormality is there. You just need to know this. There's an inferior herniation of the cerebellum. Then you can have an associated syringomyelia or syrinx. These are just for your information. It's good to know that these things are existing along with these patients, and that is why these patients have some anomalies when you do these abdominal reflexes examination. So tethered spinal cord, Arnold-Chiari malformation or inferior migration or the inferior displacement of the cerebellum, then presence of dilated central canal or the syrinx or syringomyelia can be there. These patients, the patients with syrinx and Arnold-Chiari, they may be asymptomatic. They may not have any symptoms when they see you at a younger age. These things, then they may ask you about a neuromonitoring. If a case is kept, an X-ray is kept on scoliosis, they can ask you about neuromonitoring because these cases are now done in many of the centers. So they can ask you about what are the types of, maybe they'll keep you a reading of the neuromonitoring reading. If you get any graph and other than a nerve conduction study, you have to assume it is a connected with the spine. You think of a neuromonitoring data. They can ask you what are the types of stimulations that you're looking at. There are mainly two. One is motor evoked potential and other one is SSEP or somatosensory evoked potentials. So somatosensory evoked potentials and transcranial motor evoked potential. These two things are things which you need to know. That may be another questions. So sensory is from below upwards. Motor is from above downwards. You stimulate the transcranial. TC means transcranial. That is, you're stimulating the cranium and the impulses are carried towards the muscles. So you record it from the cranium to the muscles, the transcranial motor evoked potential. Somatosensory evoked potential is the reverse, from the periphery to the brain. So you are checking the integrity of the spinal cord to and fro. Both these are very important. Then there can be another question: which one is more sensitive or more specific in a real-time manner? Then the answer is transcranial is more real-time because it is almost instantaneously. It gives you the answer, the reading, whereas somatosensory evoked potential lags by about 15 to 20 minutes. 15 to 20 minutes lags behind the. So these two things you have to think about, and you need to read about, just about, because these are expected questions if a scoliosis is kept. So basically, whenever you read any topic on any part, you are looking at few things. Like one is trauma, which we already covered a little bit. Trauma. Then you have tumor. Any system, any upper limb, lower limb, any system, hip, spine, whatever. You have trauma, tumor. Then you are talking about infection. So infection, very commonly what you see is tuberculosis. It can be any part of the spine or any part of orthopedics. Infection. Then there's something called inflammation. Inflammation is inflammatory, or like ankylosing spondylitis, rheumatoid arthritis. Those X-rays may be kept. Like a bamboo spine may be kept, and you will be asked to know what exactly is this, and you have to find that it's an ankylosing spondylitis. What is a HLA associated with? You have tried HLA B27. Those questions will be very straightforward. Then trauma, tumor, infection, inflammation. Then there'll be degenerative and degenerative, and then deformity or dysplasia. These are the usual pattern of questions. So they will try to include at least one question from each in various combinations. It could be the spine, or it could be any other part. So you need to read all these headings. So degeneration, we talked about intervertebral disc prolapse. We talked about Quadricular syndrome. That all comes under degeneration. Dysplasia or deformity, that is scoliosis, is part of that. So usually these are the common situations which you are getting in an examination in an OSCE manner, which is a clinically oriented. Then you may be given some implants. Some implants may be given to you, and then based on that, there can be some questions. For example, you can get a question on maybe a pedicle screw is kept, and then you're asked a few questions. For example, if a pedicle screw is kept as an OSCE, there can be a lot of questions. One question may be, which area of the bone gives maximum purchase or holding capacity of the screw? That may be one question. So they made option like, is it the body, is it the pedicle, is it the posterior aspect? So can anyone say which area of the vertebral body or vertebra gives maximum screw purchase in using a pedicle screw? Which part of the vertebra has the maximum holding strength when you are using a pedicle screw? Anyone? Any? Just wild guess. Is it body? Is it pedicle? Is it something else?
Pedicle.
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 Yeah, right. That's absolutely right. That's why we call it as a pedicle screw, because the screw has a maximum purchase on the pedicle itself. So then another question may be, what is the percentage of hold between the pedicle and the vertebral body? So usually they say about 80% or 70 to 80% is in the pedicle itself. That's a very strong hold, and rest 20 to 30% is in the vertebral body. So that's a rough calculation. Then another question may be, how long do you think the screw should be kept? If you divide the vertebral body into anterior, middle, and posterior column, what should be the ideal or minimum length of the pedicle screw? That can be another question. Anyone?
2/3 of the
Willing
vertebral
to?
body.
Pardon?
2/3 of the vertebral body.
Should be okay. So ideally, the pedicle screw should reach at least the posterior 1/3. At least the posterior 1/3. Okay, at least the posterior 1/3. You would see many of the X-rays. that the screws are not really long, and it's 1/3 to half is enough. Usually that's enough, because going all the way to the anterior cortex does not increase the holding capacity significantly. There is a minor increase, maybe a 1 to 5%, but majority is more than 80. You have already got it in the pedicle. So going anteriorly is not recommended in a thoracic or lumbar area, but except in one vertebral board. Which vertebrae do we ask for a complete or end-to-end purchase? End-to-end purchase we expect, or we are looking at in the sacrum. When you're putting a screw in the sacrum, we want a good purchase. Why is it? We are looking for a bicortical purchase in a sacral screw. Why is that so? Anybody can answer that? Only in the sacrum we talk about bicortical fixation. Rest of the vertebrae we don't. Why is it?
Pedicle is not pedicle.
Pedicle is? Okay, S1 has the largest pedicle. It's a very wide pedicle, but it is highly osteopenic compared to the rest of the vertebrae. The pedicle purchase is less because it's relatively less denser, and also the vertebral body is also less denser. So we are looking at getting the screw right up to this point. What is this point in the sacrum where you are all expecting the screw to get the maximum purchase? What is this point called? Any idea? Can anyone say that? The maximum dense bone is seen in this part of the. You may be given a sacrum and given a question which is most dense area of this bone. You may be asked that question. It's called the sacral promontory. Okay, I'm sure you all know about it. So it's a sacral promontory, and biomechanically, how do you want to put these screws? Biomechanically, how do you want to put these screws? Do you want to put it convergent or divergent? This is a sacrum I'm trying to show. When you want to put two screws, how do you want to put these screws to get a maximum purchase, or to minimize maximum pull out strength? Shouldn't come out of the body when you bend forward and all that. So you want to put it in a converging manner. Okay, you want to, convergent. When you put the screws in a convergent manner, these screws, one of the complication is that the screw can get loosened and pull out, especially in sacral region. So you want biomechanically, you want to increase the strength of this whole construct. So by converging, you get a lot of strength of the construct. And you will know that when you put multiple level screws, you put two rods and the screws and all that, then you must have seen a cross connector like this. Okay, so what is the idea of putting this cross connector? That may be another OSCE. You may be given a cross connector and asked why do you need to use it. You have a very good pedicle screw construct. You have good rods on both sides. Why do you need another cross connector? What are you looking at? Does it add any importance or improvement in the strength? Anyone?
Act as a single system.
Once again? Yeah, you're right. Can you tell me that again?
It can act as a single system.
Right. You are making it as a single construct. That's a very good answer. Okay. So that, you are limiting the pull out by bilaterally, you are just linking together. It is a cross link. You are linking the right and left. And so it increases the pull out by about 400%. That's what they say, about 400%. The pull out strength is increased. And so it has got another name called DTT. The cross link is also known as, they may be asked what is another name for a cross link. That is called as a DTT. It is called device for transverse traction. So usually you would see that when they put it, usually they compress it and tighten it. So, you know, there is a transversely, there is a traction happening. So this is called a device for transverse traction. So a simple question can give you a lot of, simple instruments can give you a lot of questions. And there can be one more question on these instruments. For example, you have a very long construct, you have so many screws at multiple levels. Okay, like a scoliosis case or a very long fracture, you have done multiple screws and all that. And you are going to use more than one transverse connectors. Okay. So there can be a question, where do you want to put these transverse connectors? So it's usually the upper 1/3, lower 1/3. So this is where you want to put the device for transverse traction or cross connection, so that it becomes a really strong hold, especially in a multiple level fracture, especially if the bone is weak, when there is a pathology like a malignancy, an osteoporosis, your screw strength is not very good. So you want to reinforce your fixation with these cross links. So you put it one at a 1/3 level, 1/3, 2/3, and another one again at 1/3, 2/3 levels. So this is how you can link these instrumentations and make it biomechanically strong. Then you may be asked about how do you augment these screws, or how do you increase the strength of these screws in a metastatic situation or an osteoporotic situation. How can you increase the strength of these screws? Can anyone say? You know that the patient is osteoporotic, so you know already that DEXA is poor, but you have to operate, you have to put screws, you know that it is going to pull out. So how can you increase the strength of your screws? Any idea?
Cementing.
Anyone can answer, anyone can. You want to increase the strength of the screws, how can you do it?
Cementing.
Yeah, great, that's the answer. You can use a cannulated screw, and you can inject cementing through the thing, and you can make this area a little bit stronger, and so that you get a better purchase. And then you can choose a different type of screws. There are different types of screws available, which has dual threads. You have two types of threads in those screws. You have different types of threads in the pedicle and different types of thread in the body. So that dual threaded screws also may be used to get a better purchase in the pedicular region of the vertebral body. So these are the ways by which, by converging, when using cross links, all those are the other situations. So if you may be given few instrument-based questions also in an OSCE, so please prepare. You can prepare for that also. This is it time. Can we ask some questions, get some questions? I think if they have any doubts, they can ask me. Dr. Balu, Dr. Jis?
Yes, sir. Yes, sir. Anybody who has some doubts, please, you can just unmute yourself. Please share your doubts. You can even put your message in the chat box also, if possible. Sir, I think if there is no doubts, maybe
Yeah,
you can
yeah.
wind up.
Okay.
Sir,
Yeah.
Sir, there's one doubt, I think.
Okay.
sir, yes, sir.
Yes.
Sir, in cervical spondylosis, usually we'll take the lateral X-ray. So, what is the importance of oblique views in cervical spine? Is it for to see the narrowing clearly? Is it better visualized in oblique views or?
Yeah, oblique views will give us a will show you the neural foramens. In oblique, you will see the neural foramens, and you may see some occlusion or narrowing due to the spurs, osteophytes protruding into the neural foramens. So that will give you an idea of oblique view in that scenario. But honestly, these days, because we are relying so much on the MRIs and sometimes in CT, routinely we are not doing. I'm not routinely doing oblique views, but it's a good practice that you can do it oblique views. That to see this foramen, once you see it, you will know the real shape of the foramen. You know how narrow it is. All those things are important.
Okay. Thank you.
Okay.
So there was a message in the chat box regarding some important OSCEs which may come up in the minimally invasive spine surgery. Hello, sir. So there was a question in the chat box on. Am I audible?
Yeah. Okay.
Yes, sir. Yes, sir. Regarding minimally invasive spine surgery, any important topics?
Can you stop sharing my screen? Yeah. Let me just check.
Sir, okay.
Minimally invasive spine surgeries. That's what somebody has asked. Okay.
Yes, sir.
Okay, minimally invasive spine surgery. There are two types we can roughly say. One is non-instrumented. Other one is instrumentation. So the common one is what we do is a minimally invasive lumbar disc.
Srinivas, Kekamo? I think sir lost a connection in between.
Sir, connection.
Hello. Hello.
Yes, sir. Yes, sir.
Okay. So minimally invasive lumbar discectomy, or we can say micro lumbar discectomy. These two are the commonly performed minimally invasive surgeries. Then other one is the anterior cervical discectomy, which is again a minimally invasive surgery. And these are non-instrumented, we can say. Then other ones are the instrumentation, not per se instrumentation. Then other one is the vertebroplasty and kyphoplasty. Here we are not instrumenting, actually we are injecting the bone cements. So those two also will come under the minimally invasive surgeries, vertebroplasty, kyphoplasty. Then the most commonly performed instrumental surgeries are minimally invasive pedicle screw fixation or percutaneous pedicle screw fixation. You can use it for any fractures without where you do not need a major decompression. You can do a minimally invasive pedicle screw fixation or percutaneous pedicle screw fixation. And Then spinal fusions. So there are different spinal fusions. Most commonly done spinal fusion using the MIS technique is the MIS TLIF, minimally invasive transforaminal lumbar interbody fusion. That is one option. The other one is an OLIF, or oblique lumbar interbody fusion. That's again a minimally invasive access plus percutaneous pedicle screws. These are the commonly performed minimally invasive procedures. Then they can be like sacroiliac fixation, or such screws and all can be done percutaneously. Then you can do percutaneous endoscopic surgeries like PELD, percutaneous endoscopic lumbar discectomy. So these are the commonly performed minimally invasive surgeries. To do a minimally invasive surgery, first you have to be well versed in an open case, because if the minimally invasive surgery fails during your surgery due to any reason, you have to convert that into a formal open case. So during a learning curve, you have to be very good in doing a normal, straightforward, open surgery. Then you can always advance to a minimally invasive technique, because sometimes you may end up in converting an MIS case into an open case due to various reasons: instrumentation faulty, big patient, bleeding, not proper access illumination system problem, can be some technical problems. So anytime you have to be converting, think of converting these surgeries into open surgeries if it's not working the way you wanted it. Thank you.
Thank you, Krishnakumar. It was an excellent talk. So with the diagrams and everything, it was very informative. Thank you very much.
Okay, thank you so much. Sorry for the disturbance in between. Thank you all.
Thank you, sir. Thank you, Krishnakumar, sir. It was a wonderful session.
Okay, thank you.
Thank you, sir.
Thank you, sir.
Bye.
Thank you, sir.